Welcome to NSG 222, Study Session 1, Basic Concepts in Medical Surgical Nursing. Headache. Introduction. One of the most common types of pain experienced by humans is headache. Most people have at one time or the other experienced headache, and that perhaps includes you and me. It affects people as frequently and commonly as hunger and thirst. In the process of your study in this session, the meaning of headache, the different types experienced by humans, and how each type of headache occurs will be explained. Also, you will learn about how to recognize and differentiate the different types of headaches. Learning outcomes. At the end of this study session, you should be able to 1. Define headache. 2. Highlight the different types of headache and their causes. 3. Describe nursing assessment of patients with headache. 4. Identify the drugs used for headache. The meaning of headache. Headache can be described as pain in the head. It is an unpleasant sensation in the region of the cranial vault, area below the orbit, eyes, spreading over the scalp and back to the occipital region. Jacobs and Giles, 1985. Headache is also called cephalgia. Figure 1.1 shows the cranial nerves involved in pain perception. The structures that are sensitive to pain include the following: venous sinuses, the dura, blood vessels of the cranium, 3 divisions of the cranial nerve, V, trigeminal nerve, CNVII, facial nerve, CNIX, glossopharyngeal nerve, cranial nerve X, vagus nerve. Others include the first 3 cervical nerves, Lewis, Elkemper, Dachshund, O'Brien, and Butcher, 2007. It must, however, be noted that not all tissues of the cranium are sensitive to pain. Headache, primary headache, secondary headache. Headache is an unpleasant sensation in the region of the cranial vault, area below the orbit, eyes, spreading over the scalp and back to the occipital region. Primary headache. There are majorly 3 types of primary headache. These are given in the figure below. Tension type, migraine, cluster headache. Tension type headache, TTH. Episodic TTH, chronic TTH. Tension headache is the most common type of headache. It is usually associated with bilateral location, referred to figure 1.6. The individual experiences a feeling of pressing and tightening in the head. Tension type headache is also associated with emotional and physical stress, which result into contraction of the muscles in the neck and scalp. It ranges from mild to moderate in intensity. Symptoms of tension headache are made worse with activities. According to the International Headache Society, IHS, there are 2 forms of tension type headache. These are episodic TTH. The individual experiences fewer than 15 headache days per month. Chronic TTH. The individual experiences 15 or more headache days per month. Chronic TTH differs in mechanism and often results in disability than episodic TTH. Individual with chronic TTH tends to overuse medication. Mechanism of TTH. Some schools of thought initially believed that TTH was due to sustained and painful contraction of the muscles in the scalp and neck. Recent evidences, however, do not support this theory in all patients. Empirical evidences suggest that TTH occurs due to increased excitability of the central nervous system, which is generated by repetitive and sustained pericranial myofascial inputs. Benson and Jensen, 2009. In addition, there appears to be tenderness of the pericranial myofascial tissues in patients with TTH than LD adults. Webinar with animation. This tenderness is positively associated with the intensity and frequency of TTH. Benson and Jensen, 2009. Other biochemical pathophysiological implications show elevated levels in calcitonin gene-related peptide CGRP in the peripheral circulation, being positively associated with chronic TTH. Clinical manifestation. This is characterized by a bilateral pressing, tightening pain from mild to moderate intensity. Patients may experience either sensitivity to light, photophobia, or sensitivity to sound, phonophobia. The two sensitivities do not occur together. Mild nausea, anxiety, and depression may occur in patients with chronic TTH. Diagnostic studies. A detailed and careful history taking is very important. Diagnosis is done by physical examination, electromyography, EMG. The test may reveal sustained contraction of neck, scalp, and facial muscles in some patients. Cluster headaches. Cluster headaches are a rare and less severe form of vascular headaches. As the name suggests, this type of headache comes in clusters of 1 to 8 daily, with excruciating pain around the eyes and orbit. Pain radiates to the facial and temporal region and is accompanied by tearing and nasal congestion. Bronner and Sudat, 2010. Cluster headaches produce pain around the eyes, temple, forehead, and cheek, usually unilateral and always one-sided. The pain is usually excruciating and occurs once or twice per day. Pain is usually relieved by walking around. Headaches usually last for 4 to 8 weeks and goes into remission for months to years. Other features of cluster headaches are facial flushing or pallor, rhinitis, nose drooping, and restlessness. Causes and pathophysiology. Actual cause and mechanism is not fully understood, but the trigeminal nerve is believed to be implicated. Cluster headaches are associated with a dysfunction of the intracranial blood vessels, the sympathetic nervous system, and pain modulation systems. The characteristic circadian rhythmicity of cluster headaches indicates that the hypothalamus plays a role in its development. Cluster headaches also run in families, meaning that it has a genetic component. Smoking and alcohol are also related factors. Migraine headaches. Migraine headache is a recurring headache characterized by unilateral and bilateral drooping pain, usually triggered by events or factors. Has a familial tendency and its manifestations are associated with neurologic and autonomic nervous system. Migraine headaches tend to be supraorbital, retroorbital, or frontotemporal with a throbbing quality usually severe and relieved by lying down. Causes and pathophysiology. 1. 3 theories are proposed. These are a sudden vasoconstriction, which is followed by vasodilatation, results in changes in the blood flow, causing the throbbing headache, webinar with animation. The associated pain is due to muscular tension in the head, webinar with animation. Biochemical changes in the serotonin pathway result in the pain in the head, webinar with animation. Stages of migraine headache. In some people, migraine headache occurs in stages that are described in Figure 1.5 below. Prodromal phase, aura phase, headache phase, recovery phase. Prodromal phase. The phase is not sharply defined in all sufferers. It is characterized by psychological symptoms, depression, irritability, gastrointestinal symptoms, food cravings, anorexia, and changes in fluid balance. Aura phase. This is described with a sensation of light or warmth, usually associated with a spreading depression and wave of diminished cerebral blood flow, referred to as oligemia. Oligemia begins from the occipital lobe of the brain and spreads towards the frontal lobe at the rate of 2 to 3 mm per minute. During the aura phase, the individual may take his or her medication to prevent a full-blown attack. Symptoms include visual disturbances, light flashes, bright spots on one side of the visual field. Others are mild confusion, slight weakness in the extremities, drowsiness and dizziness, animation. Stages of migraine headache. Cluster. Pain is in and around one eye. Tension. Pain is like a band squeezing the head. Migraine. Pain, nausea, and visual changes are typical of classic form. Headache phase. Patients tend to hibernate at this phase. This means that they hide from sound, light, odors, people, or problem. The headache is usually throbbing in nature, which may be incapacitating synchronizes with the pulse rate. The duration of this phase varies from 4 to 72 hours. Recovery phase, also referred to as termination and postdromal phase. This phase is characterized by gradual cessation of symptoms. Patients commonly experienced contraction in the neck and scalp muscles, localized tenderness, exhaustion, and mood changes. Patients may also sleep for long periods of time. Diagnostic studies. Diagnosis of migraine is made on the basis of history. There is usually no need for routine diagnostic tests, except when abnormalities are found on neurological examination. Such tests may include head computerized tomography, CT, magnetic resonance imaging, MRI. Nursing assessment of patients with headache. The effective management of headache is dependent on accurate nursing history. Therefore, we must ensure that detailed history of the patients is obtained. To make it easier, the mnemonic cold spell described by Weber and Kelly 2007 may be particularly helpful in exploring the symptoms reported as you and the client ask and answer questions during health interview. Table 1.1 gives the description of the mnemonic. Description of the mnemonic. Characteristic. Describe how the headache feels. Is it throbbing, sharp, stabbing, etc.? Onset. When did it begin? Location. Where in the head is the pain? Switching of sides, frontal, etc. Duration. How long does it last? Any recurrence? Frequency. Time of the day of occurrence. Severity. How bad is the headache? Pattern. What makes it better and what makes it worse? Is it related to events? Alleviating factors. Any visual disturbance, tearing, photophobia, etc. GIT symptoms, nausea, vomiting, depression, irritability, etc. In addition, it is important that you explore the history of headaches, previous illness, trauma, and allergies of your client's family. You can suggest that the patient keeps a diary of episodes with specific details. This record will be helpful in future to determine the type of headache and associated factors or triggers, as well as serving as a clue to the cause of the headache. Also, you will find functional health pattern model described by Major Lee Gordon very helpful in organizing to obtain history from the patient under the following headaches. Health perception, health management pattern. Take note of positive family history, previous method of managing headaches, drugs taken in the past, etc. Nutritional metabolic pattern, types of food and drinks such as alcohol, caffeinated drinks, monosodium glutamate, etc. Note feelings of vomiting, anorexia. Activity exercise pattern. Ask for feelings of tiredness, fatigue, fainting, weakness. Sleep rest pattern. Inability to sleep, insomnia, insufficient sleep, feeling of not having rested after waking from sleep. Cognitive perceptual pattern. Not a unilateral severe throbbing, possible switching of side, disturbance of vision, sensitivity to light, photophobia. Dizziness, tingling or burning sensation, migraine. Severe one-sided headache, nocturnal, at night, nasal stuffiness, cluster. Bilateral band-like, dull, persistent, occurring at the base of the skull, neck tenderness, tension type. Cognitive perceptual pattern. Not a unilateral severe throbbing, possible switching of side, disturbance of vision, sensitivity to light, photophobia. Dizziness, tingling or burning sensation, migraine. Severe one-sided headache, nocturnal at night, nasal stuffiness, cluster. Bilateral band-like, dull, persistent, occurring at the base of the skull, neck tenderness, tension type. Self-perception or self-concept pattern. Not feelings of depression. Coping stress. Tolerance pattern. Stressful events, anxiety, irritability, withdrawal, and what he or she does to help such feelings. Role, relationship pattern. Effect on work and family relationship. Nursing diagnosis. The nursing diagnosis which you can make include, but not limited to, the following. Acute pain related to mechanism of headache as evidenced by patient's complaints of throbbing and crushing pain. Altered comfort related to the throbbing sensation in the head. Impaired sensory perception, visual, related to photophobia. Altered self-concept related to repeated episodes of migraine headache. Knowledge deficit related to precipitating factors of headache. Ineffective coping related to stress. Nursing goals. The goals of nursing care of a patient with headache include: patients will communicate reduced or no pain within 1 hour of nursing intervention. Patients will experience increased comfort within 1 hour of nursing intervention. Patients will use positive coping mechanisms to deal with chronic pain after 72 hours of intervention. Patients will demonstrate understanding of the cause of condition and readiness for enhanced coping. Nursing interventions. Interventions will depend on the identified cause or nursing problems. The following information may be used: assist patients to examine lifestyles and identify stressful events and precipitating factors. Teach relaxation techniques and suggest alternative ways to deal with pain, e.g., exercise, meditation, self-hypnosis, imagery, etc. Assist to identify helpful coping strategies and learn to cope with situations appropriately. For tension-type headache, encourage patients to use relaxation techniques. Patients with migraine usually require a quiet, dimly lit environment. This should be provided. Patients with migraine usually require a quiet, dimly lit environment. This should be provided. Triggers such as foods containing amines, cheese, chocolate, nitrates, hot dogs, vinegar, onions, monosodium glutamate should be identified and avoided. Others include caffeine, alcohol, red wine, nicotine, aspartame caffeine, etc. Nursing evaluation. After the nursing interventions, you need to evaluate to see if you have achieved the nursing objectives completely or partially, or not achieved at all. In case the objectives are not met, then you reassess the patients. Drugs used for headache. In the treatment of headache, different drugs are used depending on the type of headache. Tension-type headache. For the treatment of TTH, usually non-opioid analgesics are effective, e.g., aspirin, acetaminophen, used singly or in combination with a sedative, muscle relaxant, tranquilizer, or codeine. Lewis et al. 2007. Cluster headache. Cluster headaches respond to prophylactic drugs such as verapamil 6 ml, lithium, ergotamine tartrate, and non-steroidal anti-inflammatory drugs, NSA IDS. Migraine headaches. Mild to moderate migraine, non-opioids are effective. Moderate to severe. The triptans are the first-line drugs because they selectively affect serotonin receptors, thereby treating the primary cause of migraine. In addition, triptans reduce neurogenic inflammation of the cerebral blood vessels and produce vasoconstriction. Examples of the triptans include sumatriptan, Imitrex, naratriptan, Amag, rizatriptan, Zomig, electriptan, Relpax, almotriptan, Axat. Some drugs have been found to prevent migraine headaches. The following are included on the list: beta-adrenergic blockers, e.g., propranolol, Injurial, atenolol, tarnomin; tricyclic antidepressants, e.g., amitriptyline; selective serotonin reuptake inhibitors, e.g., fluoxetine, Prozac; calcium channel blockers, e.g., verapamil, Isoctine; clonidine, Catapres. Summary of study session 1. In this study session, you have learnt that headache is described as pain felt in the head. Basically, there are two types of headache: primary and secondary. Primary headaches are tension type, migraine, cluster headaches. Nursing management is dependent on the types of headache. Nursing history is a key factor in management. End of study session 1. Thanks for listening.